Okay, cheers Rob.
My name is Rob Worthington, my student number is 363614. So a presentation today about obesity and non-communicable diseases in the UK. We're trying to tie together the effects of obesity with type 2 diabetes, coronary heart disease, leading to heart attack, and also depression. C3, Collaborating for Health, are a charity that put together a briefing paper for the House of Lords in 2011, and they try and put a distinction together for the differences between diseases that are dependent on certain risk factors and also the ones that can be made considerably worse or better with understanding the application of certain lifestyle choices. We're going to concentrate on, like I said, type 2 diabetes, coronary heart disease and depression. In the report, they identify 4 major non-communicable diseases. Cardiovascular disease, which includes our coronary heart disease, type 2 diabetes, cancer, and chronic lung disease. Now, non-communicable diseases are responsible for 36 million deaths a year, over 60% of deaths in the world. It's double all the deaths that are from infectious diseases, including AIDS and TB, malaria, and 40% of these deaths people are under 60. Within the report, C3 also recognised mental illness as a non-communicable disease. Now, they also established that 80% of premature deaths can be prevented by tackling just 3 risk factors, and that's poor diet, which includes alcohol, smoking, and then lack of physical activity. Still with C3, the World Health Organization and the World Economic Forum projected the cost to the world economy of non-communicable diseases $47 trillion over the next 20 years, 16 trillion due to mental health issues. Now, the non-communicable diseases we're concentrating on, along with obesity, have also been called the disease of affluence, or the Western disease, because it's all due to lifestyle that accompanies economic development, food availability, enhancement of technology leading to less manual work, also private transport. Now, it also tends to affect and disadvantage the lot, so it really should be called the disease of the poor. To overcome these factors, you need to concentrate on behaviour more so than treatment. Not necessarily taking away the necessary care, but increasing the awareness of prevention. And just a quick reference as well, these same diseases can be classed as hypokinetic diseases. It's a loose term to involve chronic physical inactivity and poor fitness, and it's thought to affect about 7% of the population, including our 4 things that we're looking at: obesity, coronary heart disease, type 2 diabetes, and depression. Obesity itself then, the World Health Organization gives us a definition, and they say it's an accumulation of excessive fat, and it's measured by BMI. They also give a formula for BMI there. Public Health England, they qualify the actual range for BMI as BMI of over 30. So we can really see that obesity is when excess fat starts to impact the health. Now, within the UK, the number of obese people is set to rise, really, by 73% over the next 2 decades. It's going to result in 1 million extra cases of type 2 diabetes, coronary heart disease, and cancer. Now, BMI is what we just talked about as a use for establishing obesity. It wasn't originally used as a medical term, it was used by a statistician in Belgium in the early 1800s. But in 1985, the National Institute of Health began to use obesity to define by BMI, and there were different ranges then for men and women. But in 1998, the thresholds were consolidated for men and women because the numbers were meant to be easy to remember. Nice round figures of overweight at 25 and obese at 30. But it doesn't take into account different body types like athletes, people like that. But it was argued that an attentive doctor could spot the difference. Well, if the doctor's eye is better than the actual BMI, why are we using it? So, a much better indicator, and one that's encouraged to be used now, is waist measurement. It's a measurement of abdominal obesity. Just a quick look at the history of obesity then. Now, originally we were hunter-gatherers, and the survival benefit of storing fat is established there. Now, the Foresight report actually refers to this as a core system engine. And that's when there's excess energy into it, there's a biological tendency to accumulate fat. But that brings into play the energy equation, which we can see goes all the way back to ancient Greece with Hippocrates there. this process of storing fat becomes self-sustaining, and a lock-in develops to that. And it continues to preserve energy despite the lack of physical need. That system then leads to a gain in body weight. Now, this lock-in can be overcome with self-control, which is quite hard because these forces are very strong. Even then, though, if we look at the bottom there, even then, obesity was seen as a character flaw, and obesus was a fat character in Greek comedy as a figure of mockery. Looking at abdominal obesity then, abdominal obesity is an increase in adipose tissue or visceral fat. Now, the increase of fat in this area is associated with a greater risk of type 2 diabetes, cardiovascular disease and certain cancers. Fat in this area is thought to be more metabolically active, which is referred to as dysfunctional adipose tissue. The abdominal fat causes cells to release pro-inflammatory chemicals, which makes the body less sensitive to insulin and disrupts the function of insulin-responsive cells. Public Health England, they say that a large waist is 5 times more likely to develop type 2 diabetes, and Diabetes UK say that a large waistline is a better predictor of type 2 diabetes than BMI values. So really that's what we should be using now, abdominal obesity measure. Now, abdominal obesity has been linked to metabolic syndrome. Just quickly look at metabolic syndrome and insulin resistance. Metabolic syndrome is a cluster of abnormalities, a combination of risk factors really, but the added risk is beyond that is normally expected from each factor individually. Insulin resistance is one of the characteristics. Now, we just talked about abdominal fat causing insulin resistance or affecting the insulin responsive cells. So, obesity causes insulin resistance, which itself causes more obesity, which is a vicious circle. We've got a picture here of insulin resistance. As we eat, we produce insulin, and as the cells become resistant to insulin, what tends to happen is we secrete more insulin to try and get the same effect. Much like raising your voice for somebody that's hard of hearing. Now, first thing, the body produces more insulin to keep blood sugar level normal, but over time this causes the body to lose its ability to produce enough insulin. That leads us in then to type 2 diabetes, and the House of Parliament got a proposal number 145, and it's got a few stats on there projecting that there's nearly a million rise in type 2 diabetes by 2020. Cost of almost $4 billion per year to the NHS. Now, there's 2 types of diabetes, type 1 and type 2. We're looking at type 2 today. And type 2 accounts for 90% of the cases. And of that 90% of them are overweight. And there's about to be 7 million people at high risk within the country. Still on the post note from the House of Parliament then, there's a combination of risk factors, age, family history, ethnicity. The main risk factors though tend to be obesity and physical activity. Now, obesity is thought to account for 80 to 85% of the risk of developing type 2 diabetes, or obese people are 80 times more likely to develop type 2 diabetes than somebody with a BMI of less than 22. But at the bottom there it says by losing a very small percentage of the weight, 5 to 7% of the weight, reduce the risk of diabetes by 58%. So what is type 2 diabetes? We've already talked about the body produces insulin from the pancreas to regulate glucose level in the blood. In some cases it doesn't produce enough, and in other cases it doesn't work properly, like insulin resistance. And we see some of the complications at the bottom, leads to blindness, kidney failure, and coronary heart disease in fact. So we've got a picture there of our insulin resistant cell. The glucose in the bloodstream there is only taken into the cell once insulin effectively opens the door for it. On our insulin resistant cell, we can see that less of the glucose is taken in, causing a high blood sugar level. So health promotions and strategies for reducing type 2 diabetes then. There's 2 approaches for preventing it. Individual interventions for those that are thought to be at high risk, and also for the general population, more of a wider awareness, like an education of the risk factors. Now, the National Institute of Health and Clinical Excellence, they highlight that their risk intervention, high risk intervention, tends to go along with the NHS health checks, which are locally commissioned. You go to your GP and get measured for blood sugar and cholesterol, blood pressure, and they're aiming at people between 40 and 74 years old, and they're aiming to assess 15 million people. After that, there's going to be guidance available, whether it's medical intervention or just lifestyle changes. But there's no real specific strategy for the wider awareness. It tends to be linked to the obesity strategy from the Department of Health. Prevention tips that we have for diabetes, this comes from the National Diabetes Education Programme. They stress two things really: eating a low-fat foods and reducing calorie intake, or 30 minutes of physical activity 5 times a week. And what we're really looking to do is control the simple sugary carbs that go into your system, concentrate more on whole wheat food, whole foods and fruits and vegetables, low glycemic index foods. This leads us in then to coronary heart disease, atherosclerosis and a heart attack there. Now, coronary heart disease is the #1 cause of death and disability among people with type 2 diabetes, to link the two together then. And at least 65% of diabetics die from heart disease or strokes, and are 2 to 4 times more likely to develop coronary heart disease. Now, all the risk factors for cardiovascular and coronary heart disease occur more frequently when you have type 2 diabetes. So, you can see there the risk factors that are going to increase the risk of furring the arteries, the cholesterol levels and the triglycerides. So what it causes fatty substances to block the arteries called plaque or atheromas, and this includes cholesterol. Now the arteries become restricted and may cause blood clots. If a block occurs in a coronary artery, this can result in a heart attack. Now I have a picture there of atherosclerosis. We can see that damage to the cell with plaque. It can cause a rupture in the cell wall, in the artery wall. Then we have the damage to be repaired with platelets. This clot that it causes can break off, and if the clot breaks off and reaches a narrow section where it can't pass, it actually blocks the blood vessel. And damage to large blood vessels like veins and arteries is called macrovascular disease. Damage to small capillaries tends to be called microvascular disease. And if we look at heart attack then, myocardial infarction, the blockage of the coronary artery which prevents blood going to the heart, disrupts the nutrients and oxygen to the heart then, causing a heart attack. A picture of it again there, you can see there's a blockage on one of the arteries, and it causes a little bit of death in the heart tissue there. Now, once that part of the heart has died, you can survive a heart attack, but maybe part of the heart has actually died. What that leads then to is that the blood will not be able to pump enough blood around the body to meet the body's demands, and that can lead to heart failure. And the most common cause of heart failure is a previous heart attack. And similar to type 2 diabetes, by controlling your blood glucose level, that's what can cut the risk of coronary heart disease by 42%. Preventive tips then, similar to what we talked about for type 2 diabetes, eat well, maintain a healthy body weight, minimise fast foods and sugary foods, eat more fruit and vegetables, and exercise regularly. So the same sort of advice comes into play, and it ties back into hyperkinetic disease and also the disease of athletes there. Depression, I've got a few stats for depression there. The main one being that it costs the NHS approximately $77 billion a year. Now the World Health Organization said that depression or mental disability is the #1 cause of disability in the United States and the 3rd largest behind coronary heart disease and stroke in Europe. Depression then, we have the mind.org, they have a guide to food and mood there, and there's a cause and effect. What can cause mental sort of issues, the fluctuation of blood sugar level and energy levels, the reaction to artificial chemicals and additives, and food allergies may cause it as well. Now the main foods that cause it, you can see that the main foods that cause it: sugar, chocolate, dairy products, hydrogenated fats. They're the same ones that cause weight gain. And these foods can cause health problems, which include mood swings and panic attacks, psychotic episodes, and of course, depression is what we're talking about. Now, there's a bias towards obese people, or there feels a bias towards obese people. There's a stigma that goes along with being obese. These people tend to see this, and it decreases their self-esteem and it hurts their quality of life. In fact, they're 20% of an elevated risk of depression. Now, there's various coping strategies. Some people might find that stigma might be enough to force them into losing some weight. Others actually turn to food and start to binge eat as well. So we have some examples that have been documented. In depression, if you're both depressed and obese, you're doubling the risk of carrying heart disease. Depression goes along with an increase in appetite sometimes, a decrease in physical activity, and also some antidepressants can actually cause weight gain as a side effect. It's also worth mentioning the cortisol effect. Cortisol is a stress hormone, but it's also a metabolic hormone, which goes along, it's one of the hormones that are released during abdominal obesity, and that can increase body weight and increase abdominal obesity as discussed earlier. So depression and weight gain go hand in hand. Mental tips, again, mental tips. Again, we're looking at the mind.org, and they have something called the Mind Meal, which again is the same sort of preventive tips: regular meal times, choosing proper whole grain foods and fruit and vegetables. Adequate protein. They also suggest increased physical activity, which goes along with their ecotherapy, which is outdoor activities and running. They tend to involve physical activity there. So, to eliminate the risk of obesity-related diseases, it makes sense to treat people with depression and to think about the physical consequences of mental health problems. Treatment of depression and obesity should be integrated. Now that leads on to the Eat Well plate, public health Eat Well plate there. Their outline, we can see that it goes along very well with all the outlines we've got for depression, coronary heart disease and type 2 diabetes from our different recommendations. Public Health England's healthy eating guidelines, the same thing. We need low glycemic index, fruit and vegetables. Now, the Foresight report, tackling obesity, they say that the nation is getting fatter generation by generation. They also talk about the modern society as being an obesogenic environment, which leads to passive obesity just by being in this environment. Now, what they say that the approach that's needed, it's not just individual action that's needed, it's more society and government action needed, so it's likened to climate control. Now, what the information that they used for the Foresight report tied into the National Diet and Nutrition Survey, which was conducted by Public Health England, and that's just to show how the society is actually eating, and it really does strengthen the Eat Well plate that we just talked about. Still with the Foresight report then, the strategies that they use then, that they recommend or outline, we've got a Change for Life, which tends to be the flagship for Public Health England for lifestyle, which is our large social marketing campaign. Their phrase then is Eat Well, Move More and Live Longer. Within the Change for Life, we've got the Smart Swap campaign, which is managing like-for-like swaps within the diet. So to talk about removing excess calories from the diet, then increasing fruit and vegetables. The goal then is to reduce the calories of the nation by 5 billion every day. And it's also to improve the diet and physical activity to reduce obesity and associated risks. Now, these two have been identified, the diet and increased physical activity have been identified as the big two that can be controlled for obesity then. Intervention then for individuals, we have our NHS health check programme for 40 to 74-year-olds, which we've already talked about. There are also some online self-assessment questionnaires, for example, Diabetes UK have an online questionnaire. Opportunistic testing by GPs. If you attend a GP and they think that they're going to be at some sort of risk from anything like that, they're going to be giving you opportunity testing then, which leads to lifestyle programmes and maybe medical intervention if needed. Interventions for the population then. We've got the Change for Life that we just discussed. We also got the responsibility deal, which where companies sign up voluntarily, which will then calorie labelling on their menus and maybe on the products that they have. Education-wise, we have the 5 a day, which is 5 a day fruit and vegetables. We're looking at restricted advertising. They already ban advertising to children for fast foods. Better nutritional labelling, we've got traffic light system already in place on a lot of products. There's also discussion on regulating portion size. The Food and Drink Federation suggests a range of portion sizes. We're also approaching to reformulate food, especially fast food, reducing salt and fat content, and then maybe even improving applying some food taxes, like they do in America, some in America and also in the Danish countries. This may affect the poorer people, but then again, the poorer people are the ones that are going to benefit the most from doing this. Now, we're looking at behaviour change models. We're looking at behaviour change models. We really need to understand our attitudes and behaviours before we deliver an effective health promotion. Because, as you can see, the thoughts affect our emotions, and emotions affect our thoughts. One of the first ones we can look at is a health action model from 2001. Now this relies on people having a high self-esteem for it to work, just to be able to resist peer pressure and able to be objective about the things that are being told. Low self-esteem tends to not really work, and we already established that people with overweight or obese individuals have a low self-esteem. They feel they've got limited control over their lives. So it's not really an effective health promotion for weight loss. We have the trans-theoretical model from 1982 though, that shows the different stages we have for making changes through pre-contemplation to contemplation, action, and we can see that you can relapse at any time from that circle from that circle model and re-enter the system at any stage apart from before maintenance there. So again, we've got this, it identifies the different stages of change, so it's more a tailored intervention. It can be very much an individual thing, except relapse as part of the process we just discussed. It's better suited to an individual because of the tailored approach that it has, so it's not really a great health promotion for the general population. It's been successful on an individual basis with smoking, alcohol, drugs. The next one we'll look at is the communication persuasion model. Now that's more about mass advertising and media advertising. It's an input-output matrix. We have different variables from exposure to advising others, and people can drop off at any stage. But what it assumes on, what it works on, is rational behaviour. That you can come to the right conclusions on things. Now, it has worked very well with smoking and drink driving. We can put the advertisements on the TV to show how harmful smoking and drink driving can be. But smoking and drinking tend to be choices, the actual choice that people make, whereas eating is not really a choice. Plus, it's going to be very hard to put the same shock tactics to obesity. It's hard really to show someone on the TV you're obese or having a heart attack. It's too much of a shock really to take in. But what it all ties into is the white paper from Public Health England that talks about a ladder of intervention that goes along with the coalition's core values, freedom, fairness and responsibility. Now what they're trying to do, they're trying to strengthen personal responsibility and self-esteem so you take more of an active role in your own health. And what it actually says though, is that the government will take the least intrusive approach necessary to produce the desired effect within health promotion. And what they use within the white paper then is the Nuffield Council's intervention ladder. You see the bottom of the intervention ladder there is do nothing at all, simply monitor the current situation. The right at the top is make a limited choice, so it can be compulsory activity. So they're going to move up the ladder of interventions as they need to for the health promotion to enable people to make more of the decisions themselves. Now, all the things we're talking about, obesity, type 2 diabetes, they all tend to be related in the news a lot of the time. And over the past couple of weeks, we can see the headlines that we've had about reducing the risk of diabetes and obesity-linked diseases. In fact, even this morning, this very morning, the headline on the Daily Express was the diet that's going to add years to your life, given the benefits of the Mediterranean diet. So that gives an outline of the effects of diet on our non-communicable diseases and also an approach to the preventive measures we can take.
Excellent. Well done, thank you, Rob.
Okay.